Hi, my name is Norkatis, and I'm a PhD student at the Center of Medical Physics and Biomedical Engineering at the Medical University of Vienna in Austria. Today, I would like to talk about radiation dose and patient exposure issues. In these presentations, I would like to cover the following learning objectives. First, I would like to talk about the total effective dose for hybrid imaging techniques, then talking a little bit about recent advances of PET imaging technologies, also including the novel image reconstruction algorithms that we can use for PET reconstructions, and finally, to review clinically viable approaches to dose reduction in oncology PET examinations. But first, let's talk about what is actually radiation dose. Dose, as a physical quantity, is the energy dose or the absorbed dose, which is describing the locally absorbed energy per unit mass, and it is given in gray. This is the measure that usually is used in radiation therapy. When taking into account the radiation type, since they have different biological effects as well, we are talking about equivalent dose. However, in diagnostic imaging, equivalent dose is more or less the same as energy dose, since for all the radiation used in imaging, the conversion factor between absorbed dose or equivalent dose is 1. It is important to mention that energy dose and equivalent dose are calculated for a specific organ. And when we add also the tissue weighting factor into the equation to the equivalent dose, then we get the so-called effective dose. And effective dose is the equivalent dose multiplied with the tissue weighting factor, allowing comparison between whole body and partial body dose expressed in sievert, and describes the risk related to radiation exposure of the whole body. So the effective dose is also measured in sievert as well as the equivalent dose, which is obviously a bit confusing. The effective dose of 1 sievert describes the hazard related to irradiation of the whole body with 1 gray of photon radiation. If a person receives a whole body dose, the tissue weighting factor is 1. However, in medical imaging, usually only a portion of the body is exposed. The tissue weighting factors allow comparison of a whole body dose to a partial body dose, and also allow comparison between doses to tissues of varying radiosensitivity. It is important to note that the radiosensitive tissues have higher weighting factors. If the weighting factors of all organs would be added together, they would equal 1. The important take-home message from the dose measures would be that this is the measure of the risk related to the radiation exposure, and in comparison to equivalent dose or absorbed dose, this is not a real physical quantity, but it describes the risk of the radiation exposure. So now, knowing basically all the dose quantities that are interesting for us, let's see how is dose in hybrid imaging. So when we talk about hybrid imaging, probably the first system that comes to our mind is the PET-CT and how this actually works. So I'm pretty sure everybody knows that first we acquire a CT image, as shown in the animation. So for example, a whole body CT imaging, and then we also have in the same system mounted the PET detectors, so basically the patient is repositioned and just shown in an animation as an older system like a step and shoot instead of a continuous bed motion. We acquire different bed positions to cover the whole body of the patient, and when everything is acquired, then we actually fuse the images. But the important part that those in hybrid systems is coming actually from both modalities that you need to take into account, computed tomography as well as the injected activity that we give to our patient. Looking in more detail into PET image acquisition, so first we inject the patient with the radio tracer, and after a certain amount of time, we position our patient inside the PET scanner, and then we detect all the photons, and we store the information in a raw data in a list mode format or can be a sinogram. But at this stage, we still don't have any images. So we need a so-called image reconstruction algorithm that we can use to convert the measured data into PET images. The image reconstruction is a really important step because this is the part of the whole workflow when we can actually correct for the different physical processes, and also we can make our PET images in this way to look better. So let's just really keep into mind that we have a raw data that we can use, we can also work with it, and then also we have the image reconstruction, because this later will be important. So I just mentioned earlier we need to take into account both modalities. But what is dose in nuclear medicine? So we have a radioactivity injected inside the patient's body. So the first that we need to consider is the dose deposited at the point of the decay. Furthermore, we also need to take into account the dose deposited by photons interacting with tissues. When they're leaving the patient's body, they undergo different interactions when dose is deposited. It's really important to note that dose depends on the spatial and temporal distribution of the radioactivity. But for us, it's really important how can we estimate the dose in diagnostic nuclear medicine. And for this, we can take into account the trace kinetic is assumed from published kinetic data, as well as the patient anatomy is estimated from simplified models. And in order to calculate the effective dose, we can use the predefined conversion factors and multiply it with the injected activity. It is also important to mention at this stage that the calculated dose is an approximation for a standard patient. Since it's really important to know, and this is part of the dose actually received by the patient, how much activity we inject to the patient, by the European Association of Nuclear Medicine, there was defined a dosage card for pediatrics where the injected activity in megabecquerels can be calculated based on a baseline activity and a multiple. For example, in case of an 18 FFDG PET brain scan of a patient of 50 kilograms in weight, the administered activity should be calculated as the baseline activity, which for this type of examination is defined as 14, and multiplied with this multiple based on the patient's weight, and this would be in this case around 150 megabecquerels. So this is basically what is important in dose for the PET imaging. But we know that there we also have the CT that we need to take into account. So dose in computed tomography is similar. So the X-rays from an external source are passing the patient, and on their way, the dose is deposited by the photons interacting with tissue when passing through the body. And here is really important to mention that the dose depends on the output of the X-ray tube, which can be obviously set, the patient anatomy, as well as the size of the field of view. And one of the easiest ways to basically reduce dose delivered to the patient is by setting the right field of view for the imaging. But how do we calculate dose in computed tomography? In comparison with PET imaging, actually calculating the dose in computed tomography is a bit more challenging. The dose calculation can be done with Monte Carlo simulations and cannot be performed in clinical routine. So the dose estimation in practice is actually a slice-dependent conversion factor from Monte Carlo simulation of a standard patient. And a really easy approach is a mean conversion factor for a scan region, which can be expressed as the dose length product with the mean conversion factor, and this is frequently found in literature. And we also need to mention in this case that the calculated dose is an approximation for a standard patient. So let's assume that we acquired a PET-CT image of a patient and we would like to calculate the effective dose for the whole scan. And how can we do this? So basically looking at the images in the DICOM header information for the CT, we can derive the CT dose index volume values as well as the scan length. When multiplying these two values, we come up with something called the dose length product for the volume, and multiplying this with the conversion factor for the CT, we can calculate the effective dose for the CT examination. For the PET, as we just discussed a bit earlier, we know the injected activity that we give to our patient, and of course we also know the conversion factors, and multiplying these two values, we actually find the effective dose for the PET. Summing up the effective dose for the CT and for the PET, we have the effective dose for the whole PET-CT examination. At this stage, we know how to calculate the effective dose for a whole examination. So let's have a look at the technical advances of the PETs in the past years that can help us to reduce the injected activity to the patient and in this way to reduce the effective dose. So the new scanners has a way bigger increased sensitivity. At UC Davis, it was developed a new scanner called the Explorer, which has an extended field of view from 20 centimeters from the regular scanners to 2 meters. In this way, it's possible to acquire a PET image of the entire body way less time, reducing scan time, and obviously having a way higher sensitivity, leading to better image quality. On the other hand, due to the new digital detectors using silicon photomultipliers, we have a much better time of flight resolution. For example, for one of the new Siemens scanners for the Vision PET-CT, we have a time of flight resolution of around 220 picoseconds. And finally, we also have advanced image reconstruction methods incorporating sponge-fed function modeling that can improve image quality, as well as other image reconstruction modalities that we will touch a little bit later on, where we are not using a PET-CT but a PET MRI, where we can use the MRI information for the PET image reconstruction. Let's talk a little bit more about time of flight. In older scanners where we don't have time of flight capability, but the two photons are detected forming the line of response, along the line of response we don't know where these two photons are coming from. When two back-to-back photons are emitted by the annihilation of the positron inside the tissue, the photons reach two opposite detectors of the PET scanner at different times. The time of flight difference is proportional to the path length difference of two photons, and this provides information on the position of the annihilation along the straight line, joining the detectors. In fact, the position is blurred by a time measurement uncertainty named time resolution, which depends on several factors. The smaller the time resolution, the smaller the error on the localization of the source it is. The space and time uncertainty are proportional to the equations shown here, where c is the speed of light. The time of flight can help increase the signal-to-noise ratio, and it improves images with decreasing time resolution, and it was shown in previous studies that it's larger for larger patients. The time of flight signal-to-noise ratio is proportional to the non-time of flight SNR through the following relationship shown in here. So now we covered the basics of what is dose, what measures for dose do we have, how we can calculate the effective dose for the CT, the PET imaging, and also some of the advances in PET imaging that we can use to reduce the injected activity and in this way to reduce the effective dose. I would like to now show a few examples that we've been working on to study how low can we go with the injected activity. And to do this, when we acquired the raw data in list mode format, we wrote a piece of script that we can use to virtually delete counts in the acquired list mode raw data and simulate low count levels. So when we have our list mode data originally, we assign random numbers for every event inside the list mode, and then applying a threshold value, we deleted all the events which were above our threshold, and in this way we generated new list mode datasets with reduced amount of counts, which obviously would be as a reduced amount of injected activities. For this study, actually we've been looking at whole body PET-CT oncology cases for pediatric patients because we were also interested in the effect of time of flight. As we've shown before, that the SNR gain using time of flight is more evident for larger patients. For this study, we simulated virtually different count levels from 100 down to 10%, and then we used different image reconstruction techniques. So we used the standard OSM algorithm, then we added resolution recovery, the PSF, and then we did all these reconstructions with and without adding the time of flight information. And we tried to be as close as possible to the clinical routine that is used. And I would like just to show a few examples. For example, in this case, there is a pediatric case with two lung tumors. On the top row marked with yellow, you can see the PSF reconstructions directly from the vendor, and on the bottom one, you can see the PSF with the time of flight information added to it. So what we can notice first, that when we reduce the number of counts or the injected activity with 50%, we still see comparable results to the original images that would have been used or were used. as well as the same can be seen also when the TOF is there. However, when the time of flight information is there, we see a higher contrast for the images with a bit of less noise. And I mentioned earlier that there's the ENM dosage card, and for this particular patient, we wanted to see how much would this reduced injected activities correspond to what the ENM is actually recommending. And then we realized, interestingly, that the activities that were injected to these patients actually correspond to 75% of the dosage card. So this was already a reduced amount of injected activity, in this way a reduced amount of effective dose. And if we just reduce this amount by 25%, going to 75%, injected activities where we almost can't see visually any differences, we are already at half of the recommendations by the EANM. Another interesting study that I would like to mention was where we were looking at non-lesional epilepsy patients who underwent PET MRI scans. The data actually was a dynamic scan, but for our purpose of the study, we used the last 10 minutes of the data, and we had access to T1 MR images as well. The injected activities were fairly high, and then for this study as well, we used the same methodology to virtually reduce counts in the list mode data. Since in this case we've been using a PET MR and we had an MR image of the brain, we could use some advanced image reconstruction algorithms which actually take advantage of the MR information for guiding the PET image reconstruction. And I would like to show directly how this looks like. So we have the standard awesome images, which are really blurry. And of course, we need to apply a post filter on them to get rid of the noise, but we kind of blur the images, so not many details are there. When we add resolution recovery, point spread function into the reconstruction, then the contrast increased, but still, as usual, the images are blurred or filtered afterwards with a Gaussian filter. However, when we use the MR information for the reconstructions, there are different methods. We obtain way nicer images. So in the AMAP reconstruction, first, it's a bit more challenging since we need to segment the different parts of the brain, and that we need to use for reconstructions. But for the asymmetrical Baucher reconstruction that you can see over here, then we can directly use the MR information. And it's also possible to set the different weights, like how much this information should be used by the algorithm. And we see way more detail than as a standard OSEB reconstruction and way higher contrast for our imaging without having noise. But what actually happens if we reduce the counts while using these reconstructions? So for the standard PSF filtered images, when we go down with the counts, it starts to become more noisy. However, when we use PET reconstructions with the MR information added to them, we can maintain the contrast and detail of the images even at really low count levels, like going down to 50 or 35% of the counts for the same images. And in this way, significantly reducing the effective dose received by the patient. In conclusion, this is everything I would like to cover in this really short amount of time of 20 minutes to talk about a little bit an effective dose described, the risk from radiation exposure, that we really should use reasonable means to help reduce effective dose levels. I did not have more time to show more data on how it looks like when we reduce the injected activity for PET scans. This is just a few pilot data from clinical studies. We can see that actually the new advances are helping to reduce the injected activity if the suitable image reconstruction methods are selected. I would like to thank you for your attention. If you have any further questions, please don't hesitate to contact me via my email. I will try to answer all the questions. And I would like to thank also my colleague, Ivo Rausch, who is providing slides for me for this presentation. Thank you very much, and hopefully see you next year in Vienna.